Good afternoon, everybody. It's good to see everybody here, and it's lovely. I'm surprised you're not outside. It's very sunny and beautiful. I was out there at lunch. It was great. So we're going to talk about antibiotic prescribing, and I really do try to update this every year and do the latest information. Some things don't change, some things do. Even if it's an old guideline, I try to find new data. So I know some of you have been to my talks before, but I hope that you always will take away something you can use in your practice when you go back to work on Monday. So let's get started. The learning objectives are, we're going to just talk about general antibiotic resistance, and it's going to be a bigger topic as we go every year because it's becoming a bigger problem for us, and we all contribute to antibiotic resistance with our prescribing. So we really are going to spend some time on that. We're going to talk about local antimicrobial resistance patterns and how you can know what your local patterns are and not just someone's urban legend that down the hall they're saying, well, I always use this because we have all this resistance. So you're going to be able to figure out how you can know in your local area how you have resistance. We're going to look at commonly used antibiotics and the resistance patterns and then recommendations for practice. So antibiotic resistance, this is a huge problem, and it's not getting any better. It's getting worse. They estimated, the CDC in 2013, there are about 2 million antibiotic-resistant infections annually in the U.S., about 23,000 deaths from resistant infections. And what the CDC did is they published a document in 2013 really prioritizing certain pathogens, whether they were urgent. So those urgent ones are C. diff, CRE, and gonorrhea. And then they also have, they look at urgent and serious. And you'll be surprised when you see the serious one, because we all think MRSA is much more urgent, but there's a lot of concern about C. diff. One of the concerns has been pneumococcus, and if you were practicing in the mid to late 90s, we were all told to increase our dosing of amoxicillin because of resistant pneumococcus. But also in the late 90s, we started giving kids PCV7. And what has happened as we have used pneumococcal vaccines and we have appropriately vaccinated kids, and now with the PCV13, actually pneumococcus is not as resistant to amoxicillin as it used to be. It's actually much more sensitive. And I think it's because, one, we are vaccinating, and also we are more judicious, I hope, in our prescribing. Our old standby Septra, our TMP sulfa that we've been using forever for UTIs, basically has a lot of resistance now across the country. It's somewhere between 20 and 30%. And so you need to know your local resistance patterns for this one, because it may be possible that you're not able to prescribe this anymore as first line for UTIs. And we're going to talk a little bit more about that. When we look at Klebsiella, E. coli, and Proteus, we have growing resistance to our third generation Cephalosporins, and I'm going to show you a map in a minute that shows how that has grown over the years. And it's actually a very serious problem now to have all this resistance. If we do not do something to turn this around, and that means every single one of us who are in our clinics prescribing every single day, there is a predicted 10 million deaths a year from antimicrobial resistance by 2050. Now that's not that far away, you guys. Hopefully most of us will still be alive by then. And that's very scary for those of us that look at antimicrobial resistance and the growth across the world. And so what I want you to take home today is, every time you prescribe, you need to think about, is this the right antibiotic? Do they need an antibiotic? And is this going to contribute to resistance if I am doing it just because? Because I see sometimes what I see is people, they write the antibiotic because of parent pressure. They write it because they're pretty sure it's viral, but they just want to cover them just in case. That all adds up and leads us to a problem that's not going to get any better unless we change our prescribing habits. So antibiotic resistance is not only in our prescribing, but it's also in the antibiotics that our animals are using, and it's a big problem. Pew has really focused, they're spending quite a bit of their money. They're a charitable organization, but they are very concerned about this 50 million, in 2050 we're going to have 10 million deaths. I mean, that, if we don't do something. So they're working both on the human side and the animal side to get us to think about reducing our antibiotic use. So animals are getting the antibiotics in their feed, and then they develop resistance, and then the resistant pathogens are in the stool, and then it gets on like the lettuce or the spinach or whatever, and then we eat it, and we now have this resistant pathogen that is we're affected by. How many of you guys, I mean, it's almost every other month you're hearing on the news, there's an outbreak of, was it spinach or bean sprouts or, you know, whatever, like bagged lettuce. That is what we have to worry about now. And so one of the things that's happened is on the animal side, they have put some new regulation in around what animals can get antibiotics, and they can't routinely give them anymore. And now they have to actually have a veterinarian involved in the process, where before they could just go down to the feed store and buy a whole bunch of antibiotics and give it to the animals. So it's a complex process, and there's many pieces to this problem. We need to do our part of the pieces. So when resistance enters the human side, patients get sick, and then they expose other people to the resistant pathogens, and then we sort of are stuck with these resistant pathogens on the human side. So on both sides, we need to pay attention to this. When we look at our most urgent threats, C. diff is a big problem, okay? And it can cause life-threatening diarrhea. We all know that. That's nothing new. But the fact that we have so many patients with it, there's at least 250,000 infections a year requiring hospitalizations. And that doesn't count all the people we see in clinic that are positive for C. diff that never get hospitalized. So the actual number is probably 2 to 3 times that. It's about $1 billion in excess medical costs for C. diff. That's a lot of money. And the deaths related to C. diff increased 400% between 2000 and 2007. And what has happened is the C. diff itself is becoming more resistant and harder to treat. So once they get C. diff from our prescribing antibiotics, then we have to treat them with is getting more difficult. About half of the people are younger than 65, but most of the deaths are patients over 65. And I know we don't care for those patients, but our patients do see and are exposed to the elderly, so they can pass that on. And so this is a significant problem. It is predicted that a 10% decrease in inappropriate prescribing in the community can result in a 17% reduction in C. diff. So you don't have to take, it's almost 2 for 1. If you reduce 1%, maybe it's 2% in your practice. So you got to think about this, about every time we write, if we could reduce our inappropriate prescribing, we can reduce this C. diff that's out there. CRE, Carbapenem-resistant Enterobacteriaceae, is E. coli, all right? So that's our E. coli and some of the other pathogens, Klebsiella. These are ones that are resistant to nearly all antibiotics, and that's why they're an urgent threat. If a patient gets these, they have a really poor outcome. We had contamination of the colonoscopes up at one of our health systems in the Seattle area with CRE, and a whole bunch of patients were hospitalized, and there were a number of deaths because of the scope from one patient that had resistant CRE was then used, and it had to do with the manufacturer's directions around cleaning or something, but all these other patients got it, and there were a number of deaths. And so this is a very serious one because we don't have anything to treat it with. There was about 600 deaths from Klebsiella and E. coli in 2012, 2013. But if we don't do something about this, it's going to increase. The concern is that we're going to get more and more patients with this resistant pathogen. And the reason this is scary is we really don't have anything to treat it with. Gonorrhea, drug-resistant gonorrhea. It used to be we could treat gonorrhea with pretty simple antibiotics. And it wasn't even that long ago that we could treat it with the fluoroquinolones. But the fluoroquinolones have been overprescribed that now you can't, it's not even recommended to use the fluoroquinolones anymore. So you're really down to, ceftriaxone and really, what they're starting to see resistance to azithromycin, to cefixime, and ceftriaxone with gonorrhea. So that is pretty scary when you get fewer and fewer antibiotics to treat an infection. That is pretty common. The serious threat levels, there's a bunch of them. I've just highlighted some of them because I think they impact us in pediatrics the most. Fluconazole-resistant Candida. So this comes about because so many people are treating thrush with fluconazole. It's like taking a sledgehammer to an ant. You don't need a big, broad-spectrum antifungal for 10 days for Candida as your first-line therapy. What happened to gentian violet? What happened to plain old nystatin? Yes, it is a pain to do it 4 times a day, and yes, you do have to treat the patients, but if we're not really thinking about not using that as first line for something like thrush, we're not going to have it available to use it for any type of Candida infection. It's already developing a lot of resistance. So rethink your practice every time you write that prescription. Could I have used nystatin? Could I have used some gentian violet? Did I instruct the family about how to use this so that we don't have to build up to using fluconazole? And I put MRSA on here. We're all worried about MRSA. I think what most people think when we think about resistance is we think about MRSA, but it's only one of the many pathogens we have to worry about when we are thinking about prescribing. MRSA itself is a serious threat. The interesting thing about MRSA is 1 in 3 people carry staph in their nose, okay? And so we all have staph, but 2 in 100 carry MRSA. So it's not as prevalent as most people think, but when someone gets MRSA, it's really difficult to treat, and we want to make sure we're using appropriate antibiotics. And this is why we want to make sure that we're using appropriate antibiotics in the first place so that if they get MRSA, we have something to use. There's still about 11,000 deaths a year from MRSA, especially if someone's getting MRSA pneumonia. That is pretty deadly. So what you need to know is your local antibiogram, okay? That is your local resistance pattern, and this is developed by your local lab, and it depends on where you live, whether it's going to be in your hospital lab, whether your health system lab, whether your county lab. It varies from place to place. Sarah Martin, she was handed out a little card for all the providers. They had a little laminated card that they gave so that they could get their the Lurie Children's Hospital antibiogram. So I just want to show you what we have here. This is our for E. coli and to use TMP sulfa at Seattle Children's. We have only about a 86% sensitivity rate. And so you can't use it very well in some patients, and other patients you can. Sorry, there's my thing. This is the gram positives and gram negatives. There's usually a chart for each one of them. And so we need to know what you can use. And like I said, you just have to find where your antibiogram is. Sometimes you can go into your intranet and just type antibiogram, and it'll pop up. That's how I did for Kaiser, and Kaiser had an inpatient and an outpatient antibiogram. So I'm in an outpatient setting. I can figure out what the resistance patterns were in that setting. Because what you don't want is someone down the hall going, well, there's a lot of resistance, so I always use this really broad spectrum thing. And that may be not accurate. That may be just their thoughts and not true evidence. I told you I'd talk about our spread of resistance. So these are some regional maps looking at resistance that have spread over the last 15 years or so. And the top chart is the prevalence of third-generation resistant pathogens to those CRE isolates. So that's our E. coli and stuff. And the bottom one is the resistance to extended spectrum beta-lactams. And this is among pediatric patients. So this is really our bread and butter. And what is concerning is if you look at the ones on the left, The light is the best one. Okay, so there's very little resistance in the mid-90s, and as we've gone through time, the resistance has increased, and if you are living in the middle states, you have the most resistance, because the dark is the worst, okay? So right down the middle is where you see the most resistance to these pathogens, okay? And it's gotten worse over time. I'm going to compare that to the prescribing of antibiotics in the United States. And this is community antibiotic prescribing. It's based on pharmacy billing data. So these are prescriptions that were filled in the outpatient setting. And as you notice, the states with the lowest resistance, also light is good on this one, also have the least amount of prescribing. And when you look at the data, that in the West, we prescribe half the number of antibiotics per person that the people down in that dark area in the middle and the South, okay? Now, I don't think people are sicker. I don't think the ear infections are worse. You do have more resistance, but it's a true correlation between the number of antibiotic prescriptions written and the amount of resistance you're seeing. So those of you who are in the dark areas really need to think about, you're running out of things to prescribe, and do you really need to prescribe an antibiotic? Because I don't think the kids with otitis media are necessarily sicker in Oregon or Washington than they are in Texas and Louisiana and Alabama. Now, just to reassure you, if you would put immunizations on here, that West Coast would be the dark ones, because we are not good immunizers, okay? So we're not perfect at everything. All right. All right. So let's talk about what we're prescribing for, and we're going to go through some guidelines. These are the things that we do every day, and I use the most common infections we're writing antibiotics for. So just a reminder, when we're thinking upper respiratory, so we're thinking about ears and sinuses, there's 3 big bugs that we think about. We think about strep pneumo, we think about H. flu, and Moraxella catarrhalis. We also, because there's all those stars there, we have to think viruses, because since we've been immunizing kids against pneumococcus, we've kind of taken that out of the picture in many patients. And so, and that used to be the most prevalent pathogen. And so in our kids that are vaccinated, we need to think very high likelihood that we're dealing with a virus in this upper respiratory area. The otitis media guidelines were updated in 2013. There's nothing new and exciting about our change in what we're doing here. They did give us pictures to know, so that we know what we're doing when we're treating otitis media. And you know, this did evolve. How many guys were in practice 20 years ago? Okay, do you remember that when the kids came back, that if their TMs didn't look perfect, we gave them another round of antibiotics? Yeah. So now what they're saying is they need to look bad. It needs to be pus, it needs to be bulging, it needs to be, you know. So the whole idea that those TMs need to be perfect needs to go away. We need to relook at, is it bulging? Is it have impaired mobility? Is the fluid cloudy? Okay, so not just red and not just a little, what my preceptor used to call murky, okay? And that was enough to get antibiotics if it was murky. And so, so that is you know, we really need to pay attention, and you shouldn't just give antibiotics if there's just fluid, okay? We all know that, right? That's nothing new. High-dose amoxicillin is still first line, and it does work, especially since we've been vaccinating. The sensitivity to amoxicillin has actually gone up. And so it actually works better now than it did 10, 15 years ago. And so it works, it's cheap, it tastes good, it's got all the things we need for prescribing. So we should be using amoxicillin first line in those kids that haven't had antibiotics recently. If they've had antibiotics recently, then you need to go to second line. So you need to think about either something that's going to treat a beta-lactamase resistant pathogen and something that's going to, these patients are much higher risk for resistance. So that's when you think about high-dose augmentin, ceftonir, or one of the others. I love the new duration of therapy. Because you know why people want Zithromax? It's once a day for 5 days, right? And it's easy. But it's not the right drug to get. Oh, by the way, did you see Zithromax on the list? No. Okay. They haven't added it since last year either. Okay. So The duration of therapy is really nice to be able, with those older kids, to do a shortened therapy. You don't have to do 10 days once they're over age 6. You can do it for 5 to 7 days. 5 days works fine most of the time, okay? And those 2 to 5-year-olds only need 7 days of therapy. So you need, and the problem is a lot of the EMRs automatically have it set at 10 days. So you have to go in and shorten it and redo it. We at Kaiser had finally, they did age-based dosing. So our Epic was, if it's this age, you do this, and they had put these guidelines in for us. But if they don't, where I'm working now, they don't. So every time I have to go in and recalculate the amount that they're getting. This is the table that talks about first line for patients that are penicillin allergic versus not allergic. And Ceftonir or Omnicept is for penicillin allergy. And I'm going to talk in a bit about cephalosporin allergies a little bit. And then if they've had antibiotics in the last 30 days, you can use Augmentin as your first line, or you can use Cephalosporin or one of the other cephalosporins. If you have treatment failure after 48 to 72 hours, you step them up. The thing is, if you start with Augmentin, you're supposed to step up to ceftriaxone, okay? Is Zithromax on this chart? Okay, Zithromax should not be in your armamentarium anywhere anymore for otitis media. The resistance is pretty high to those pathogens, and the idea that the parents ask for it, but it's not the right pathogen. It's not the right antibiotic for the pathogens we're treating. Now, I did do a big review of the literature around the cephalosporins. I decided that, okay, you got your patient is allergic to penicillin, you put it in, and your EMR gives you this big yellow, like red or blue or whatever it is, to say, don't do this. So there's been quite a bit of literature on this. There's a retrospective chart review done at National Children's Hospital. They looked at children that were reported allergic to penicillin or anything in the penicillin antibiotic. The 513 patients were identified as penicillin allergic, and they gave cephalosporins to 24% of them, and they only had one documented non-anaphylactic reaction, okay? And so then Terrico and Gallagher did this review of the literature. It was like a 50-year review of the literature, okay? And what they found out is that there was very little cross-reactivity in the cephalosporins and the penicillins. And they figured it was less than 5%. And Campana also did a large review of the literature, and what they said is that these are their exact words. Although a myth persists that approximately 10% of patients with a history of penicillin allergy will have an allergic reaction when given a cephalosporin, the overall cross-reactivity rate is approximately 1%. Okay, when using a first-generation cephalosporin, or even less. And so one of the things that they talk about is similar structure. Okay, so if it's a similar structure to ampicillin and amoxicillin, that you have a little higher likelihood. But generally, the structure is not similar enough that you are not going to have a cross-reactivity. So this is why the AAP guidelines say when you're penicillin allergic patients to try a cephalosporin. Because one, it's not, many times they're really not even penicillin allergic. They got a rash, and so someone said, okay, never give them amoxicillin again. But nobody looked at the rash to say, is that really hives? Is it really an allergic rash? Or is it an amoxicillin rash? Or is it a rash? Did they have, roseola or something? So one, you have misidentified allergy. And then the true cross-reactivity is very low, somewhere between 1% and 5%. And so that's why it's worth trying the cephalosporins, because you are actually treating it with the right antibiotic for the right pathogen. Okay, so macrolide. So that's our friend Z. I call it vitamin Z. If you've been to my talks before, parents see it as vitamin Z, providers see it as vitamin Z. Someone goes, oh, I just give Zithromax. I'm like, that's not the right thing to be given for that, okay? The main thing, and there is a pretty high resistance to this, and the problem is that the pathogens you're treating, okay, have a very high resistance to the macrolides. Somewhere, you can read it somewhere between 8, or some things say 10 to 20, but definitely you have a lot more problems with treatment failure with the macrolide than you do with either an amoxicillin or a cephalosporin. But people go, oh, but they got better. Well, guess what? They probably had a viral infection if they got better, or you were lucky that they were the ones that weren't resistant. But we need to really back off. On this committee I sat at the CDC here in Atlanta. I came here twice this year before this for meetings about reducing inappropriate antibiotic prescribing in the outpatient setting. And when we look at the data across the country, across the age range, 70% of azithromycin prescriptions are written inappropriately. Write it down, 70%. So 70% of the time when we write, it's inappropriate. And that is based on looking at the diagnosis that the pathogen you're treating and the antibiotic that's written. Really, there's only a couple times we should be using azithromycin in pediatrics, and we're going to talk about that in just a little bit. So not for otitis media, okay? All right, sinusitis. There was 2 rounds of, actually there's 3 sets of guidelines, okay? There are the 2012 guidelines from the Infectious Disease Society, there's the 2013 guidelines from the AAP, and there's new 2015 guidelines from the American Academy of Otolaryngology, Head, Neck, and Surgery, okay? So everybody has their idea of what we should be doing. This is one of my favorite diagrams. You can get this from the AAP. If you go to the document at the AAP website and the pediatrics website, you can actually download this as a PowerPoint. At Kaiser, we made handouts on this because this is what a normal cold looks like. A normal cold, you have fever for a couple days, the runny nose gets worse until about day 4 or 5, and then it starts to get better, and it lasts about 10 days or so. If we say 10 to 14, then of course they're not back in your office at day 9. But what you see, how many of you have the patient show up on day 4 or 5 and they say they're getting worse, right? Does that sound familiar? The cold is getting worse. Now, this is really nice if you have this diagram and say, look, it's supposed to get worse. You're right on track. This is where it's supposed to get worse. And then about day 6 or 7, it starts to get better, okay? We don't need antibiotics on day 5 because the nose is getting worse, okay? And this is how we can teach our families what a normal cold is. Because we do not help them when they come in and say it's getting worse and they need antibiotics by writing an antibiotic prescription for a virus. We need to educate them that it's totally normal for it to get worse for a few days and then it gets better. Okay, what you need to watch is where that fever peak is. If that fever peak is happening day 6 or 7, that's not normal, okay? It's totally normal for that fever to happen the first 2 to 3 days. The fever should be going away, but the nose gets worse, the cough is going to get worse, they're going to be up all night coughing, the parents are going to come in and say, we were up all night coughing, and it's getting worse, and you're going, yes, I know, that's a normal cold. A normal cold is going to get worse, and then it's going to get better, so just hang in there a couple more days, it's going to get better, okay? This is from the ISDA guidelines. They have a term that they use called double sickening, or persistent and non-improving. So persistent and non-improving is the cold that's lasting longer than 10 days, okay? And non-improving, so it's not their nose is still running at 10 days, it's they're not getting any better. So that would be the bell shape that went up and it stays up, okay? Not the one that's coming down and getting better. So non-improving at 10 days, or double sickening. And those are the kids that are spiking a temperature day 6, 7, 8. They shouldn't be spiking a temperature at that age. They shouldn't be getting worse and worse and having fevers late in the course of the illness. And so those are truly the definition of a sinus infection in adults and children. The AAP guidelines are very similar. I just like this diagram. It's really kind of splits it out. So what they say is if they don't meet these, don't treat them, okay? And if they do meet these criteria, and you need to think about what their risk for resistance is. If they have risk for resistance include children under age 2, over age 65, daycare, prior antibiotics within the last month, prior hospitalization in the last 5 days, comorbidity, or immunocompromised. Those patients go down the right-hand side and they get a higher amount of therapy and a longer course of antibiotics. If they have low resistance, you do first-line antibiotic therapy. If they don't get better, here we go. I gotta get my thing going. Oh, come on. There, okay. If they're not getting better in 3 to 5 days, then you would go up to a second-line therapy in your patients that had low resistance likelihood. And if they're not getting better in 3 to 5 days, you step them up also. But you want to really start thinking about, remember how we used to put them on antibiotics for sinus infection, then we put them on another one, and then we put them on another one, and so what they're really saying is 2 times, then you need to be sending them to ENT and figure out why they're not clearing. So you want to sort of think about that. But really, we need to make sure we're really treating a true sinus infection in the first place, that they're meeting the criteria for a sinus infection, and you can actually, in the older kids, the AAP guidelines still say 10 days in younger kids, but in our teenagers, I'm only treating for 7 days for a sinus infection. Then the AAP guidelines are sort of treat until they're better for 7 days. If you start with a more resistant one, you want to treat for 7 to 10 days. The AAP guidelines talk about whether it's severe bacteria worsening. The one thing the AAP guidelines talk about is doing a watch and wait approach to a sinus infection. So if they're getting to day 10 and they're still not better, to kind of wait for a couple days, ask them, can you hold out for 2 to 3 more days and let's see if it gets better before you're starting those antibiotics. So really kind of waiting out there almost 2 weeks if you can, especially if it's uncomplicated and your patient's immunocompetent. Amoxicillin is first line, and this is a big change. What the AAP guidelines say is to use regular dose amoxicillin. So how many of you remember when you used to prescribe amoxicillin at 45 to 50 per kilo? It was a while ago, and in mid-90s is when we made that change. But really what they're saying is that if they're over age 2 and they've had no antibiotics for 4 weeks, you do not have to use high-dose amoxicillin anymore. Because if they're immunized and they're not in daycare, they're not in high risk, they really don't need that big guns. If they're at high risk and they have a risk for resistance, you can use high-dose amoxicillin. And the AAP guidelines say you could start with Augmentin if you want. The problem with starting with Augmentin is you don't have anywhere to go, right? So you have to think about, if they're under age 2, you don't want to put every kid on Augmentin. If they're under age 2 and they haven't had antibiotics for a while, I still start with amoxicillin because then you still have some latitude of what you can go to if it's not getting better. And so you can go either way on that. Maximum 2 grams a day. If they're penicillin allergic, you can use ceftonir, cefuroxime, cefodoxime, any of those. And what they're saying, if they are type 1 allergy, you should be using clindamycin and cefixime. Okay? Is the azithromycin on there? No Z packs, no vitamin Z for sinuses either. Okay, same pathogen, you've got a bug-drug mismatch. Okay? I'm not going to ask you to hold your hand up if you give azithromycin for sinus infection, so I do not want to know, okay? It is awful. I mean, I go visit students in the clinic, and they're like, they've had a runny nose for 3 days, I'm going to give them azithromycin. I just want to bang my head against the table. I'm like, this is not right. And if we don't stop doing it, we are not going to have azithromycin anymore. How many of you guys remember when we had Lorabid? How many remember Lorabid? Remember how good Lorabid tasted? And the kids loved it. Those of you who are new practitioners, you're going, what the heck is Lorabid? Well, that was one of those great antibiotics that we overprescribed that we can't use anymore because it's resistant, okay? C-chlor was before Lorabid. That was also really good taste. That used to be first-line for otitis media when I was a new practitioner. And guess what? We can't use that because we have so much resistance to it. So if we are not careful, we don't save azithromycin for when we really need it, we're not going to have it anymore. So we do need to pay attention. Second line antibiotics for sinusitis, after 3 days, so it's not 48 to 72 hours, you need to wait at least 3 days. I always tell the parents that those sinuses are much harder to penetrate. It has to work its way through all that snot, you know, and really work. It's going to take a little bit longer to start to get better with a sinus infection than an ear infection or strep throat. And so if after 3 days they're not getting better, then you can think of a second line. And once they're better, you treat them for 7 more days. So that's where you treat them 10 to 14 days. And those are the AAP guidelines on that. If they're not improving in 3 days, then you step them up to a higher level of therapy. We don't want to use any TMP sulfa. You can use doxycycline in older kids or adolescents if you want. A lot of people forget about doxy. That's a good respiratory drug because we are so afraid of it because you can't prescribe under age 8. But you can prescribe it for older kids if you need to. Duration of therapy. So this is, we've got everybody, you can do anything and be okay, all right? You could just cite somebody else's guidelines. Okay, so the AAP, which is WALD, basically says the optimal duration of therapy has not received systematic study for sinus infection, okay? The AAP guidelines say 10 days or 7 days after improvement. Most people get better in 3 days. The ISDA, the Infectious Disease Society, say 5 to 7 days. The new, the head and neck surgery guys, they say 5 to 10 days. So really, you can treat it for whatever you want. Because you, like somewhere between 5 and 10 days, okay? You know, and the thing is that we still are probably treating viral infection in many of these kids anyway. So, you know, that's probably why they get better. Anyway, I was really working hard this year to find a definitive answer on how long. And all I can tell you is everybody has a different idea. Okay, sinus infections, you want to make sure that you're using the saline nasal spray to loosen that stuff up. I know the kids don't like it, but the sinus ostia is a very tiny little drainage hole, and if they've got crusties on it, it doesn't drain well, so they need to get up in there and wash that stuff out of there. They also, it just sort of makes them feel better. Topical decongestants are fine if they're old enough to be upright when you can spray it in their nose. So about 6 years old or so, you can use some Afrin or neosynephrine. If they're young, you don't want to use it because if you get too much in there, it actually is toxic. So you really only want to do the spray, and you don't want to, unless you're buying the baby drops. There's a couple brands of baby drops you can use. But generally, I just recommend in the younger kids use a bulb syringe. And the parents say that their 2-year-old hates it. I'm like, yeah, just wrap them up in a towel and go at it. Don't use corticosteroids for sinus infections. Sometimes the ENTs will use it for chronic sinus infections, but the data is really not good on that. Okay, moving on to community-acquired pneumonia. There were guidelines in 2011. In kids, we need to think about the different pathogens we're dealing with, and it really changes across the age, okay? So in our young infants, we need to think about chlamydia pneumonia in those 4 to 16-week age. In chlamydia pneumonia, remember, it shows up as a staccato cough. They're tachypnic. They have crackles. They don't wheeze, okay? The wheezers probably have bronchiolitis, all right, a viral pneumonia. So they don't wheeze, and they kind of have these diffuse infiltrates on their chest X-ray. You want to do a chlamydia-specific IgM serum test to confirm that, but they do get zithromycin. We're going to talk about that. And then the most common pathogen in our immunized kids that are 2 to 3 years old is a virus. And then in our older kids, we need to consider mycoplasma. And I'm going to talk about actually the incidence of mycoplasma in just a minute in those older kids. We also have to worry about community-acquired MRSA pneumonia. These kids are really sick. You're not going to be sitting in your exam room going, well, do you think it's MRSA? No, you're going to be calling in the ambulance because these kids are really sick if they have a MRSA pneumonia, okay? You're going to be sending them to the peds ICU. And I can't say enough about viruses. You know, RSV is about 23% of viruses in under age 5, of pneumonias, I should say. Under age 5, RSV is 23%. Human metapneumovirus is about 8.3%. Adenovirus is 3.4%. Influenza virus is 9%, parainfluenza virus is about 3%. So viruses are about 50% of pneumonias in younger kids, up to 80% in those 2 to 3 year olds that are fully immunized for Hib and PCV. So think about that. Antibiotic choices in kids, if they're fully immunized under age 5, you're shooting for bacterial pneumonia, even though it's probably a virus. Nobody is saying don't use antibiotics at all yet. I mean, they're sort of saying think it's probably virus, but they aren't. There's nothing like, oh, don't give them antibiotics at all. So you want to give them amoxicillin. If they're allergic, you're going to give them clindamycin or macrolide. Unimmunized. If they're unimmunized, you need to worry about the fact that they might have Hib or pneumococcus. And I put PC, oh, if they're unimmunized with Hib or PCV, these kids get ceftriaxone until they're afebrile, and then you're going to switch them to an oral, probably amoxicillin. If you have chlamydia suspected in those tiny babies, they can have azithromycin. So yes, vitamin Z for them. So those little babies that you think it's chlamydia, they can have azithromycin. Kids 5 and older. Now, how many of you in your training program, they said, under age 5 you give amoxicillin, over age 5 you give azithromycin? Okay, and most people were taught that, but actually the new guidelines say to use amoxicillin, and the data is that when they are young, in the general, overall it's about 20% of pneumonias are mycoplasma, but in the young school-age kids, it's only about 9 to 16%, okay? And in the older school-age kids, it's 16 to 21%. The older adolescents and college-age students is 30 to 50%. So that's why now the recommendation is for those school-age kids is to give them amoxicillin, especially if they have fever and they're looking like it's bacterial versus a mycoplasma, okay? So you want to give them amoxicillin for 10 days. If it looks like an atypical pneumonia, those are the ones that used to call it the walking pneumonia. They don't look as sick. Or they're an older adolescent, a young adult, then those kids do get azithromycin or another macrolide. And you can use doxycycline, okay, if they're over age 7. So don't forget about doxycycline. Doxycycline is actually first line a lot of places for adults with pneumonia. So, so there you go. There is the time you can write for a Z-Pak. And I ask my college students, because that's the one, I use actually azithromycin to teach half-lives because almost every student in the room has had it. So it's a great example of how to teach half-lives. Okay, strep pharyngitis, only about 20 to 30% of sore throats are strep. There's probably over 7 million visits a year coded for strep. But there's a lot more that are written for antibiotics. When you looked at what's coding for strep, 53% of the time they were given an antibiotic, but only 17% of the time were they coded for strep. So make sure if you are treating strep, you're coding for it, because those of us sitting here in a conference room over by the CDC campus, and we're looking at the data of the prescribing practice of everywhere across the country, what we have is we have ICD-9 codes and we have antibiotic prescribing, okay? That's what we look at. So if you're not coding it correctly, it looks like you're not doing what you're supposed to be doing. So that's one thing. And we all know we're only supposed to be treating for positive streps, right? And that a positive rapid is pretty accurate unless you've got a carrier. So we're going to talk about carriers in just a minute. So even though it's positive doesn't mean they have an active strep infection. The Red Book guideline and the ISD guidelines say penicillin is first line. 250 if they're under 250 BID if they're under 27 kilos, 500 BID if they're over 27 kilos. That's pretty simple. You can use IM penicillin 1 dose if you want. And you can use amoxicillin 50 per kilo once a day. So I started at Kaiser, that's what I did all the time, or I use penicillin. If they didn't like penicillin, I give amoxicillin. And it was never a problem. I go to this new practice, I write for amoxicillin once a day, 50 per kilo, and I get a call from the pharmacist and said, this isn't the right dose for amoxicillin. And you don't give it once a day. And I'm like, well, the Red Book guidelines since 2009 have said that this is an appropriate thing to do. But clearly it wasn't. I moved to a new community that wasn't doing that type of prescribing, so I had to do some education about what was appropriate guideline-based prescribing. And you can use a first-generation cephalosporin such as Keflex. Keflex tastes good. You can use a BID for, so if they really don't like the taste of penicillin, They can use Keflex, and you can use Duracef. You can use clindamycin if you can get them to take it orally. That stuff tastes nasty, but that's 3 times a day dosing, but you can use it. If they're penicillin allergic, the recommendation is to use cephalexin, okay? And like I said, that tastes good is BID. If they have an immediate type 1 hypersensitivity, use clindamycin or macrolide. So this is the only time you get to use a macrolide for strep throat. It's if they have an immediate type 1 hypersensitivity. What is that? What is that? Like immediately they get hives, okay? Immediately they break out. Immediately they start having problems. Not the kid that, oh, they had a rash, and so we don't ever give them a penicillin anymore. So, you know, those kids should probably get a Keflex, get some cephalexin, all right? And don't forget, you have different dosing of azithromycin. If you're giving it for strep, it's 12 milligrams per kilogram per day for 5 days. I also got a call from the pharmacist about that one, because I did have a kid who was allergic to everything, and all the cephalosporins and everything. And they're like, this isn't the way you dose it. I'm like, yes, it is for strep, you know? So it was interesting. I mean, it's sort of like it's interesting when you move communities and you have all new pharmacists you have to work with. Clearly, the people in the community I'm working with aren't doing the guidelines. The one thing that to know, though, that strep has really high resistance to the macrolides, okay? And that it's up to 20% in some part of the country. So if you're using azithromycin, you need to recognize that there's a greater risk of resistance than there is to the penicillins. And I had some unnamed provider that I was working with, and because I was saying, what's the deal? The pharmacist doesn't know anything about once-a-day amoxicillin. He goes, oh, I just use Zithromax. And I'm like, okay. All right, not only is it the wrong antibiotic to use unless they're penicillin allergic, but you know, there's a lot more resistance. And so anyway, it was just interesting. This is the penicillin allergic patient. Sorry, I didn't move my slides forward. Okay. Up. Come on. What's going on? There we go. Okay, so let's talk about carriers, because sometimes what you're looking at is you're looking in the throat and you have, you know, maybe your nurse has already done the strep and you've got this positive strep and you look in there and it doesn't look that bad, you know? And you're going, what do I do with this? It's really important to know that a lot of kids are asymptomatic carriers, okay? So if they have a sore throat and you do a strep test, it being positive doesn't necessarily mean they have an active strep pharyngitis at that point. They can be a strep carrier for months, okay, up to 6 months after a strep infection. And they can be asymptomatic, and that's a huge problem. And so, you know, so positive strep doesn't always mean, so you want to, if it doesn't really look like strep and you're not worried about it, you can, you know, do a culture and make sure they would still be positive. But the main thing is that eradication therapy is not needed unless there is a reason for it, okay? So the Red Book says that it's not indicated for the large majority of chronic strep carriers. However, there are special situations in which eradication of carriage may be desirable. 1, during a community outbreak of acute rheumatic fever, post-streptococcal glomerulonephritis, or invasive group A strep infection. So that is when you would want to think about eradication of carriers. 2, during an outbreak of group A strep pharyngitis in a closed or partially closed community. So that's when a family keeps passing it around and around and around, and you can't get rid of it. That might be a time you want to bring them all in and figure out who the carrier is and treat them. 3, in the presence of a family or personal history of acute rheumatic fever, because you don't want to have a strep carrier in a family when there's someone who's had acute rheumatic fever, because they have great risk of getting that. I like this one. In a family with excessive anxiety about group A strep infections. So if the families are worried, you can go ahead and do eradication therapy. Or when a tonsillectomy is being considered only because of carriage, okay? Not because of repeated infections, but because of carriage. So these people, you can give them clindamycin for 10 days, you can give them augmentin for 10 days, you can give them penicillin plus rifampin for 10, you give penicillin for 10 days and then rifampin for the last 4 days to get rid of the carrier state, okay? So not everybody needs to be worried about carrier, but You do need to think about it, all right? And think about the fact if you look in there and they don't look like they're strep and the strep is positive, they could possibly be a carrier. Or if they have a positive rapid strep and you give them antibiotics and they're not getting ready, and they should be better in 2 to 3 days, right? And they're not better. They're still saying, oh, I have a really bad sore throat. It's not any better. It's not any better. It's probably viral and they're a strep carrier, okay? So giving them a bigger gun antibiotic is probably not going to make a difference. It's probably viral, all right? Or it's not group A strep. Okay, skin and soft tissue infections. We all know about impetigo. The new Red Book guidelines from 2015 say you can use topicals. Even, remember how it used to be if they had more than 5 spots, you went oral, and less than 5 spots, you did topical. Well, mupirocin actually have the least amount of resistance of all the antibiotics, and so for staph, and so actually it's really the best thing to use. So topical Bactroban or mupirocin works great, twice a day for 5 days. If you give them oral therapy, you want to use dicloxacillin or cephalexin for 7 days. Okay, so that's pretty straightforward. If this kid looks pretty bad, I probably would give him oral therapy if I know they're going to take it. Cephalexin tastes good, so you can do that. Dicloxacillin, good luck in getting that stuff in him. All right. There are some new some new skin infection, soft tissue infection guidelines that have come out. We all know what this looks like, Staph aureus. IND is the primary treatment when you have those big, ugly-looking bullae without cellulitis. This one does have cellulitis, but if they don't have cellulitis, you just want to use nice, warm, moist heat and IND and really kind of let it go. And I know that that makes people very anxious, but most studies indicate an 85 to 90% cure rate whether you use antibiotics or not if they don't have cellulitis. So if you don't have that big red ring around it, just IND it and don't give them antibiotics. This is the Red Book guidelines. They have a nice algorithm here. If it's mild, they're saying, IND them, and then if your culture is indicated, then you can give them antibiotics. So this is where you need to know your local resistance pattern. Can you use Septra or not? Do you have to use clindamycin? Do you have to use doxycycline? We locally have very low resistance to Septra, and we can still use it. Sorry, my voice is going. It's my third talk. Okay. This is the Infectious Disease Society guidelines. Very similar. They both have nice guidelines, but this one has these nice circles, and they really talk about purulent skin and soft tissue infections versus non-purulent, and they look at mild, moderate, and severe, and they walk you through the guidelines. Once again, if it's mild, you want to just IND it. If you have non-purulent and cellulitis, you're going to give them antibiotics. You give them oral antibiotic if it's mild. If it's moderate or severe, you're going to think about parenteral antibiotics. And this is where you start looking at using your bigger guns like your vancomycin or some of the others. But I think if we're better about using our lower antibiotics, then we don't have as much of a problem. Plus, we get them in as fast as possible when it's still just a little thing that we can IND versus a big, huge one that has a lot of cellulitis. Once it's big, we really need to use parenteral antibiotics. And you want to do good coverage for your local staph, aureus, and resistant staph organisms. So the antibiotic choices, many places in the country you can use the TMP sulfa or clindamycin. If they're over 8, you need to think about doxycycline. Are you guys using doxy? I mean, people don't think about using doxy, but you can use doxy. If it's non-purulent cellulitis, make sure you're covering for both community-acquired MRSA and beta strep. So you want to think of combining something like cephalexin and dicloxacillin or amoxicillin with tetracycline if they're over age 8. And these guys only need to be treated for 5 to 7 days. So you don't need to do 10 days. I don't know, we all treat for 10 days because that's what we treat otitis media for. But when you look into the literature, there's never been any studies that say we have to treat most of this stuff for 10 days. You can usually treat them for shorter, okay? So this is the antibiogram for Pierce County where I practice. And our local resistance pattern, we have 97% of staff in our county is sensitive to TMP Septra, okay? But I have spoken across the country and people look at you like, what? There's no way we could do Scepter in our area. So you need to know what in your local area you can use and then prescribe appropriately. What you need to look at is, you can't really see it very well, but if you look at the arrows on there, if you look at the use of the fluoroquinolones, ciprofloxacin has 4 down arrows, and that is the amount of sensitivity that happened in 1 year. It went down like 20%. So that means the resistance went up 20%. And so that's because people are overprescribing Cipro. And now you cannot use Cipro in our local area at all because you only have 52% of the time it's going to work at all if someone has staph. And that is the problem we are facing with the overprescribing. And that's pretty rapid in my local county area. And you guys need to know what's happening in your local area, okay? All right. I'm sorry, I get on the soapbox about resistance, but I think people really need to know what they're doing. Antibiotics are not like a light thing to be prescribing. Okay, okay, there we go. C. diff. If we continue to prescribe antibiotics, we continue to increase our patients' risk for developing C. diff. And just a reminder, it's a spore-forming, obligate, anaerobic, gram-positive bacillus, okay? And the only way to test them is to really do an immunoassay test and really figure out, but the problem is that they don't have great sensitivities. It's only 72 to 82% sensitive. So you have to, even if you're getting a negative, you have to worry about that. The thing is that if we don't, there's not a recommendation to do routine testing in children because a lot of children can be asymptomatic carriers and they shed the virus, and if they're not sick, don't worry about it, okay? Intestinal colonization in healthy infants can be as high as 50%. So if you just randomly do a C. diff on kids, they could be 50% of the time positive, even if they're totally healthy. You don't have to worry about this, okay? As they get over age 5 and adults, the carrier rate is less than 5%. So it's a much more accurate test to be doing when they're older. Because carriage is so common, we don't need to do routine testing in kids. And the thing is once you test them, they shed the pathogen for weeks, so we don't do test of cure either because they could be shedding. The problem, too, is those infants also get a lot of diarrheal illnesses, so you need to think, is this C. diff or is this norovirus or rotavirus or any of the other diarrheal illnesses they have? Because if you do a C. diff, it might be positive, and that doesn't mean you're really treating C. diff, okay? So the treatment is, if you think they have C. diff, so they're on antibiotic and they develop diarrhea, significant, not just the normal antibiotic-related diarrhea that every kid seems to get, but if they get moderate to severe diarrhea, you want to stop the antibiotics, and if it's severe, you want to give them treatment. The treatment is metronidazole. The dosage is 30 per kilo per day, or oral, or enema vancomycin, and you treat them for 10 days. The problem is there's a very high recurrence rate, and then they can be carriers, and so, that's why we don't do a test of cure afterwards. We only treat them if they have moderate to severe symptoms. We do want to talk about the families, good hand washing, because this is highly infectious, and if they're not doing good hand washing, they're going to spread it among the whole family. So the thing is that if we decrease our amount of prescribing, remember how we did each 10% decrease in prescribing of antibiotics, so for each increase 10% inappropriate prescribing, you increase your C. diff 17%. So every time we write inappropriately, we place our patients at risk of this. So just pay attention and know what you're doing when you're prescribing, and then treat the C. diff appropriately. We are about to enter a huge, you think you've heard a lot about inappropriate prescribing. Get into your seats because it's coming. There's going to be a huge nationwide campaign about inappropriate prescribing. There are committees that met that were sponsored by Pew with the CDC. They were sponsored for both inpatient and outpatient antibiotic prescribing. There's going to be a huge media campaign put out by Pew and to really, really pay attention to inappropriate prescribing. And even though, so those judicious use of antibiotic prescribing recommendations came out in 1999, and there was no change in our prescribing for respiratory infections. We're still not following guidelines. We're still over-prescribing. So because of the growth in resistance, in the president's budget last year, there was $1.2 billion targeted directly towards combating antibiotic-resistant bacteria. So some of that's going to go towards the animal side and some towards the human side. And so it's going to get big, and you're going to be hearing about it. You're going to see videos. You're going to see posters. You're going to see a huge media campaign to the public. And hopefully, if patients stop asking for antibiotics and we stop inappropriately prescribing them, we can see some change in this prescribing. How many of you have antibiotic stewardship programs in your system or health facility? I only see like 3 hands up. Is that really? Okay, there's some more. Okay, very few of you. Okay, so this is from the CDC Get Smart campaign, and this is sort of looks at the percentage of hospitals with antibiotic stewardship programs, and this is from 2014. So these ones are the lighter the better. If you don't have a stewardship program in your area, this might be something you want to get involved with, because this is really looking at appropriate use of antibiotics, and the CDC will help you. Your local county and state health department will help you develop a stewardship campaign, and they have great evidence-based information, so you're not just standing there, you know, going, wah, 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 don't prescribe. So there really is... They really want to help you. They really want everybody to not be inappropriately prescribing. So if you are interested in this topic, contact your local county or state health division. What is interesting is, do you see the colors here? The ones that have the lowest stewardship programs tend to have the most inappropriate prescribing and the highest resistance. Okay, so if you're in one of those dark states, there's a lot of opportunity. Any DNP students that need a project? There you go. There's one ready-made, ready for you. So the thing is that we have to change this. It's a nationwide problem, and we really need to tackle it in an appropriate manner with all of us every day paying attention to our stewardship of antibiotics. So in summary, one of the most important things is know what pathogen you're treating. So go back to your microbiology class that we took, I don't know, to me it was like 30 years ago, and you have to think about what is the most common pathogen in the area that I'm treating, okay? And then you need to treat appropriately with the right antibiotic, and don't prescribe antibiotics for viral infections, which we know is happening a lot. And then know your local resistance patterns so that you know, oh yeah, we can't use Septra, or we can't use Cipro, or we can't use this in our local area, and appropriately prescribe what you should be using, which is what you have sensitivity to. Don't use urban legend. Don't use the guy down the hall that says, I do Zithromax for everything, because that's the only one I've memorized because it's once a day for 5 days. But, you know, truly, I think that's why it's prescribed. The parents like it. It tastes good. It's once a day for 5 days. It's easy to prescribe. That's not why we should be prescribing Zithromax, folks. We should be prescribing it for pertussis and pneumonia that's in adolescents and chlamydia, okay? If we lose the ability to prescribe azithromycin for chlamydia, pertussis, and pneumonias, we are going to be back to those horrible drugs that nobody wants to take. So save them for when you need them so that we have them for the long term, because there is already increasing resistance to azithromycin. And we are going to be stuck if we don't have it, because it is really the only thing that works well for some things. So use it appropriately. Vitamin Z, take it off your list. Okay. All right, we have about 10 minutes left for questions, and my references are there. If you can't read them, you can email me. Okay? Thank you very much. So questions. Anybody have any questions? I can't see the hands. Okay, go ahead, right there. Oh, the number of days you treat strep, if you're treating with any of the penicillins or the cephalosporins, is 10 days. They've tried to redo those studies to see if they can decrease the carrier state, and they can. The only time you can treat strep for 5 days is if you're using azithromycin. Everything else is 10 days. So the question is about testing for mycoplasma and to determine if they really have mycoplasma. You can do that, and actually that's what the guidelines say, is you really should test for that before you treat them for mycoplasma. But that's kind of expensive, and it really, sometimes it takes a while to get the test back. So if you have the ability to get a very rapid test back and the patient has insurance, that's actually what the recommendation is. Other questions? I can't see. This light is, okay, over there, right over there with the orange shirt. Yeah, yeah.
I'll repeat the question. I love the graph you had about the typical upper respiratory infection, where it shows where the fever begins and ends, and where the runny nose, et cetera. And I think it's a wonderful resource to provide to parents. If we spouted off all this data that you just provided, which is wonderful for us, they're going to look at us and be like, so what? My child is hurting right now.
Right, right.
Do you know of any resources available out there that are sort of easy to understand, that we could sort of get the same point across to them?
Yeah, the Get Smart campaign with the CDC has posters and stuff that you can download, and you can order them. Also, a lot of local, county, and state health departments will have educational materials. That slide is actually downloadable as a PowerPoint out of the pediatrics website. And so don't download the PDF of the guidelines. Go into the pediatrics, and you can actually download that slide and use that. We at Kaiser printed that up and had it as handouts, and we also had them in every exam room. And so that you can say, look, look, it's a normal cold. And even when they weren't for a cold, they could look at it to know what a normal cold is.
Awesome, thank you.
Yeah, but the Get Smart campaign through the CDC or your local state or county health department usually has tons of free, they would love to give it to you, believe me. I work with those people. In fact, my son and I just had lunch with one of the people that works on Get Smart over at CDC, and because my son wants to work for the CDC. So, but yeah, they would love to send that to you. Yes, right here.
I was wondering about recommendations for treating asymptomatic bacteriuria, and also after you get a culture back on a urine culture, calling the patients back and stopping antibiotics when there's no growth. Because
well, I didn't include UTIs here. If they are not symptomatic, so they don't have fever or back pain and those other symptoms of a pyelo, what most people recommend in the older kids is to wait till you get the culture back before you start it, okay? Because so often you get the culture back and it's a mixed pathogen, and really what they had was a little cystitis or dysuria or vaginitis or something. In the babies, where you have to really worry, or if in kids that are febrile, you would start the antibiotics and then stop them if your culture comes back clean. But more and more, it's really okay. This is probably just a little irritation, and let's wait for the culture to come back. Because the majority of the time, they're coming back like mixed pathogen, and you're not really getting a true E. coli. Your teenage girls, those ones too, you really need to, you get mixed stuff on them too, but if they really come in and they really have that classic backache, all that stuff, then you definitely want to treat them while you're waiting for your culture. Does that make sense? Yeah. But that is hard. When you see those, we were all taught if there's more than so many leukocytes, you give them antibiotics and you wait. They're really recommending in these older kids that don't have fever and stuff to just hold out so you get your culture.
We are urology, and we see patients come in all the time that have absolutely no symptoms, but they've got a low count culture, and they're being treated with big gun antibiotics, and I was just curious what your take on that was.
But the thing is, if they've been treated inappropriately multiple times when they didn't have that, then you're dealing with resistant pathogens. So it's better that they're not treated inappropriately so that when they need it, we don't have to give some big gun things. We can use more narrow spectrum. But that's the nice thing about urine. We can always get the culture and know exactly what we're treating and exactly what sensitivities we're dealing with.
Over here.
Yes.
I am planning to relocate to Arizona. I've been out there a lot. I have a couple of friends that practice in pediatrics out there. And one of the big problems that they're having out there, and I practice in a clinic where I have a lot of new immigrants from Central America, and they're bringing in antibiotics like crazy. And every time their kid gets a cold, whatever's in the house, it could be Bactrim, it could be Azithromax, it could be Keflex. Whatever antibiotic is available, they're throwing at these kids. And in Arizona, somebody's kid gets sick, they just drive from Tucson down to Nogales, go buy some antibiotics, and then drive back home in an hour. So this, I'm sure, is contributing to our...
Oh, it definitely is. My husband does volunteering in Cambodia, and everybody just buys antibiotics all the time. And so what they have to use for infection there is they have very little left to use. So I think what you want to do is really do a hard campaign with those patients and really try to break that culture of using antibiotics for everything and work with I'm sure the health department there has got a campaign. I would get every poster, every handout, and when you see them for well visits is when you want to do the teaching. Not when they show up and they're sick and they've been up all night and they're, kids, everybody's coughing. But I think that we really need to incorporate this in well visits and as part of our overall approach to keeping kids healthy, that if we use these, it actually is not a good thing. And so I can't give you any better. It's really tough when they're able to get it over the counter. Yeah. Other questions? I can't, this light is right in my face. Okay, good. Okay. There's one over here and then one over here, okay?
Terry,
Right.
I've been hearing that sometimes people are starting to treat otitis media with Augmentin as a first line instead of amoxicillin. What's your take on that?
Well, actually, that's what the guidelines say. If they've been on antibiotics in the last 30 days, that's what the guidelines say, is to treat them with Augmentin or something wider spectrum.
So even just starting with that, if they've not been on any antibiotics,
Yeah.
that's before that.
If they're at risk for resistance, so they're in daycare, that's what the guidelines say. But, if they haven't been on antibiotics for a long time, even if they're in daycare, I go ahead and use amoxicillin, because I'd rather have some place to go than to start big and then you sort of restrict yourself. There's not much left. After Augmentin, you've got to go to ceftriaxone. Yeah. So there was somebody over here.
Hello?
Did you get the mic?
Okay.
Go ahead and speak. There
Yeah,
you are.
So I want to ask, what do you recommend for patients that maybe go to urgent care, they get started on antibiotic, and then you see them maybe day 2, day 3 into a 10-day cycle, and they don't need it? Do you recommend stopping it, or do you recommend them finishing off? What do you notice, or the literature as far as resistance with stopping antibiotics once it's been started?
Well, it depends on what they're being treated for. If they had a positive strep, you want to give the full 10 days, because they're going to look better in 3 days. But, are you talking like an otitis media?
Yes, let's say an otitis
ear looks
media that's
good?
clearly the ears look perfect, or they even started it saying it was a URI. They documented that, but started it anyway.
Then I would stop it. The shorter the course, regardless, the less resistance you're going to develop. It's the being on there long term and more repeatedly that you get the resistance. If you really think that they inappropriately prescribed in another provider did, and you really, really are really comfortable with that, you can talk to the parents and say, I think that your child really doesn't need this, and why don't we stop it and see how they do? If they look really good and they're really, I would feel comfortable with that. I'm working in urgent care right now. I spent a lot of time telling people they have a cold. I mean, one day, the whole day, I wrote one antibiotic prescription, and that was for strep. And the rest of it was viral. I did write a couple Tamiflus, but and I saw 22 kids and wrote one antibiotic prescription. So, but people come in, their kid's been sick for like 3 hours, and they want antibiotics, Okay, anything else? Okay, over here.
Hi, Terry. I have a comment. I'm also with the crew over here from Arizona. First of all, a comment, and then ask you to comment on something. I just would like to say it's an honor to hear you speak. I've been a nurse for 20 years, a nurse practitioner for the past 8, and your name has been throughout my education, and it's just such an honor to hear you speak. My second question, or ask for a response, is what are you doing as far as educate? I work in specialty care, so I work with children with spina bifida and orthopedic conditions as well. And so what we see a lot of is the children having come in from, and I'm not accusing anybody of anything, but from the primary care environment, having been treated with antibiotics for UTIs that are really not symptomatic, so basically foul odor, and the parents are coming in. And our education to our children with neurogenic bladders and bowels is to not treat those. That is not something that we would treat. They're automatically going to be colonized. So can you make a comment on that, please?
So did you come to my last talk in the last hour, which was how to submit an abstract and speak at a conference? So I'm not kidding, okay? That is what you need to go to your local nurse practitioner conference, your local NAPNAP, and you need to go and speak on it, okay? I can tell you, whoever's in their chapter, you're always looking for a speaker, right? So there you go. Go and educate the other nurse practitioners in the community about what is appropriate treatment, because they're scared. They don't want to do the wrong thing. They're thinking, okay, I'd rather treat them so that they're okay, because these kids are vulnerable. And so they are trying to do best practice. They probably don't know that it's okay to not treat them, okay? So that's what I recommend, and that's how you really start to change practice in your community, so that they're comfortable. And not only that, then they can call you up and say, okay, I got this kid, what do I do? And you could go, it's okay. It's okay not to treat them. That's, so that's what I would recommend. Then that's how you're going to change practice in your local community. All right, and my time is up. So I will be here for a little bit. Thank you very much.